Welcome to the Public Health Practice Gap, the podcast where we bridge the distance between research, policy, and real-world practice. I am your host, Dr. Bradley Fevrier, public health educator, researcher, consultant, and founder of NextGen Public Health Consultancy. Each week, I take a complicated public health issue and try to make it understandable, practical, and genuinely useful, not only for public health professionals, but for anyone who wants to understand why health happens the way it does. Today's episode begins with a single sentence that stopped me in my tracks. Jennifer Dowd, a professor of demography and population health at the University of Oxford, said recently, and I am quoting her directly, "You really can't biohack your way completely out of disease or death." I think that sentence captures one of the greatest misunderstandings in modern health culture. We have entered an era where a growing number of people believe that with enough discipline, enough money, enough supplements, and enough optimization, disease can be pushed to the margins almost entirely. It is a seductive idea. It suggests that the body is a machine we can fully engineer if we apply the right inputs. Unfortunately, the science tells a much more humble story. We are living through a genuine cultural moment around this topic. Wearable devices now track our sleep, heart rate, and blood glucose in real time. Longevity clinics have opened in major cities around the world. Podcasts and best-selling books have built around the promise of optimized, extended, disease-resistant living. None of this is inherently wrong, and much of this technology has genuine value when used thoughtfully. But somewhere along the way, curiosity about our own biology has, for some people, hardened into a belief that disease is fundamentally optional. That belief does not hold up against what we actually know about human biology. So today, we are going to talk about probability versus certainty. We will explore why behaviors matter enormously, even though they come with no guarantees. We will discuss the difference between personal responsibility and population health. And we will ask what public health should learn from the growing biohacking movement rather than simply dismissing it. Let's get started. Human beings crave certainty. We like believing that outcomes follow effort in a clean, predictable line. Study hard, earn good grades. Work hard, build wealth. Exercise, eat well, avoid disease. Life would be a great deal easier if biology followed rules that tidy. But biology does not work that way. Biology operates through probabilities, not guarantees. Imagine rolling a weighted die that lands on 6 only 1% of the time, instead of the usual 16%. I have dramatically changed the odds. I have not eliminated the possibility. That distinction is exactly what healthy behavior do for our bodies. Exercise reduces the risks. It does not eliminate disease. Good nutrition lowers risk, does not guarantee a longer life. Maintaining a healthy body weight reduces risk for a long list of chronic conditions, but it does not make anyone immune to cancer. Not smoking dramatically reduces your chances of heart disease, stroke, and several cancers, and remains one of the single most protective decisions a person can make. Yet, even lifelong non-smokers sometimes develop lung cancer. That is not evidence that prevention failed. It is evidence that probability is not certainty, and that biological systems are more complicated than any single behavior can fully control. Consider type 2 diabetes, a condition public health professionals discuss constantly. We know with tremendous confidence that maintaining a healthy body weight, staying active, and eating whole foods substantially reduces someone's risks. That evidence is not in dispute. And yet, we also know People who did all of these things diligently for decades and still developed diabetes, often because of genetics, hormonal factors, or age-related changes no amount of discipline could fully prevent. Neither outcome disproves the value of healthy behavior. Both simply confirm we are talking about risk, not destiny. Unfortunately, social media often teaches something different. Algorithms reward certainty because certainty is dramatic and shareable. Influencers promise certainty because uncertainty does not sell supplements. The message becomes, follow my exact system and you will never get sick. I want to be direct about this. This is not science. That is marketing. And the two should never be confused, especially when someone's health decisions are on the line. Bryan Johnson has become one of the world's most recognizable advocates for longevity. He reportedly spent millions of dollars every year attempting to slow his own aging. He tracks hundreds of biomarkers, follows meticulously engineered nutrition plan, and undergoes medical testing most people could never realistically assess. Whether or not you agree with his methods is almost besides the point. What his story actually teaches us is this. Even with nearly unlimited resources, biology still refuses to perfectly become predictable. Money can improve healthcare access, reduce certain sources of stress, and buy enormous quantities of personal data. Money cannot eliminate randomness at the cellular level. No amount of optimization can erase the reality that our cells are constantly changing. DNA replication introduces error. Protein misfolds, immune systems weaken with age. Aging continues quietly in the background of every day. The human body remains an astonishingly resilient system, one we should genuinely admire, but it has never been and will never be a perfect engineered one. There is something almost freeing about accepting this, rather than fighting it for a lifetime. There is a concept in statistics called regression to the mean that quietly explains a great deal of what gets marketed as a health breakthrough. When someone with an unusually poor biomarker adopts a new intervention, that biomarker often improves somewhat on its own, simply because extreme values tend to drift back towards average. That does not mean the intervention did nothing. It means we have to be careful about attributing every improvement to whatever protocol someone happened to be following at the time. This is exactly why rigorous research, not personal testimonials, has to remain our standard for separating what genuinely works from what simply looked like it worked. I want to be fair to the other side of this conversation as well. There is real value in some of what the personal optimization movement has produced. Continuous glucose monitors have helped some people understand how specific foods affect their own metabolism. Sleep tracking has helped others recognize patterns that they would never have noticed otherwise. What I am pushing back against is not the tools themselves, but the surrounding narrative that treats those tools as a path to biological exemption, rather than a one modest input among many inside a system that remains fundamentally probabilistic no matter how much data we collect. Before we continue, I want to thank the sponsor of today's episode, my notebook, When Treatment Can No Longer Cure. It explores what happens when medicine reaches the limits of what it can actually do, examining the ethical, emotional, and human dimensions of serious illness and end-of-life care. If today's conversation has reminded you that medicine cannot control every outcome, this book explores what healthcare should look like once uncertainty becomes unavoidable. You can find it on Amazon, and if you enjoy this podcast, purchasing a copy is a meaningful way to support the show. Now, back to today's discussion. One of the greatest strengths of public health is that it expands the conversation beyond individual. Medicine asks, What disease does this patient have? Public health asks, why do populations become sick in the first place? Those are different questions, operating at different levels of the same system. Individual choices matter enormously, but those choices always occur inside larger systems that either support or undermine them. Can someone safely walk in the neighborhood? Do they breathe clean air or face daily exposure to industrial pollution and heavy traffic? Can they afford healthy food on a limited budget? Do they have paid sick leave? Can they access preventive healthcare before a minor issue becomes a major one? Do they work night shifts that disrupt sleep? Do they carry chronic financial stress that quietly wears down the body over decades? These are population health questions, and the answers shape outcomes just as powerfully as any individual decision. The British researcher Thomas McKeown famously argued that much of the historic decline in mortality across industrialized nations came not primarily from medical treatment, but from improvements in nutrition, sanitation, and living standards. His specific conclusions have been debated and refined since, but the broader insight has held up as well. Populations become healthier largely through changes to the conditions surrounding them, not only through what happens inside a clinic. If two people make identical healthy choices, but one lives in a community with polluted air, limited healthcare access, and chronic economic insecurity, their health trajectories may look very different over 20 or 30 years. That is not a failure of willpower. It is context. And public health exists precisely because context matters as much as, and sometimes more than, individual behavior. There is a phrase used often in public health: your zip code may be more important than your genetic code. That statement should not be taken too literally. Genetics and biology absolutely matter, but it captures something real. Where we live profoundly shapes the opportunities and risks that surround us every single day, often in ways we do not fully notice until we step back and compare one neighborhood to another. There is another danger in believing health is entirely controllable through individual effort alone. It quietly encourages blame. Someone develops cancer? What did they do wrong? Someone has a stroke? They should have exercised more. These responses oversimplify some of the most complex diseases known to medicine. Risk factors matter, but diseases emerge from an intricate interaction among genetics, aging, environmental exposure, socioeconomic conditions, healthcare access, and a fair amount of random biological chance. The more we learn about biology, the more humility we should develop, not less. This does not reduce personal responsibility. It places that responsibility inside a more accurate picture of reality, rather than a simplified story that makes us feel more in control than we actually are. Consider telling someone with uncontrolled high blood pressure that they should simply eat healthier. That advice is not wrong, but it may be dangerously incomplete. Can they afford healthier food? Do they have time to prepare meals while working multiple jobs? Do they fully understand the nutrition recommendations being given to them? Is healthy food even available where they live? Are they experiencing chronic stress that itself elevates blood pressure? Are they able to access health care consistently enough to monitor their condition over time? None of this removes accountability. It ensures we understand the full reality before assuming willpower alone was missing. Good public health does not lower our expectations of people. It removes the unnecessary barriers standing between them and the healthy choice. I have seen this play out repeatedly in clinical and community settings through my own career. A patient is labeled non-compliant for missing follow-up appointments, when the real barrier turns out to be unreliable transportation or a work schedule that makes daytime appointments nearly impossible. A family is blamed for a child's poor nutrition, when the real barrier is a neighborhood with no full grocery store nearby. In both cases, the label of personal failure obscures a solvable structural problem. If perfect optimization was never possible, what should we do with that information? Focus on the behavior the evidence consistently supports, understanding that they shift odds rather than guarantee outcomes. Move your body regularly, in whatever form is sustainable for your actual life. Don't smoke, and if you currently do, know that quitting at any age produces measurable benefit. Eat mostly healthy, whole foods. Sleep on a consistent schedule. Maintain healthy relationships, since social connection is one of the most consistently protective factors researchers have identified. Manage your blood pressure and know your numbers. Stay current on vaccinations. Address your mental health with the same seriousness as a physical symptom. Reduce alcohol consumption. Wear your seatbelt every time. Protect the skin over a lifetime. None of this is glamorous. None of it will go viral. But collectively, behaviors like these have added decades to human life expectancy across entire populations. Public health has never depended on miracle interventions. It depends on the slow, consistent work of improving the odds for as many people as possible. That is enough. It has always been enough. Before we close, I promise we would ask what public health should learn from the biohacking movement. I think the honest answer is this. People are drawn to it because it offers agency, real-time feedback, and a sense of active participation in their own health. Public health has historically been very good at identifying what works at the population level and less good at making that guidance feel personal and engaging to any single individual. We can borrow that energy, curiosity, engagement, a genuine desire to understand one's own body, without borrowing its tendency to overpromise certainty where none exists. Wearable technology can be a genuinely useful tool for encouraging consistent movement or better sleep, even though it cannot rewrite the underlying biology of aging. The goal is not to reject the tools this movement has popularized. It is to keep them in their proper place as aids to evidence-based behavior, rather than substitutes for the harder systemic work that actually moves populations towards better health. Today's conversation is really about humility. Science gives us remarkable tools. Medicine accomplishes extraordinary things. Healthy living matters enormously, but none of it eliminates the uncertainty that comes with being human. Perhaps the healthiest mindset is not chasing perfect control, but recognizing that our responsibility is to make wise choices while accepting the uncertainty of life. As public health professionals, our job extends beyond helping individuals optimize their own health. We also work to build healthier communities, stronger systems, and policies that improve the odds for everyone, not only for those with the greatest resources. That is the real difference between biohacking, a personal hobby, and public health as a shared responsibility. One optimizes for the individual, the other works to lift the baseline for everyone, including the people who will never be able to afford a single biomarker test. If you found today's episode valuable, please subscribe to the Public Health Practice Gap wherever you listen to your podcast, and consider leaving a review. Connect with me through the Next Gen Public Health Lab newsletter on Substack and pick up a copy of my new book, When Treatment Could No Longer Cure, available now on Amazon. Until next time, health is influenced by our choices, our biology, our environment. Our job has never been to guarantee perfect outcomes. Our job is to improve the odds. I am Dr. Bryan Fevrier. Thank you for listening, and I will see you next time on the Public Health Practice Gap.